Good evening. The trigeminovascular system is widely accepted as playing a fundamental role in the pathogenesis of migraine. It's defined as being comprised of three elements: the trigeminal subnucleus caudalis, the trigeminal nerve, and the dural meningeal arteries. But in this presentation, I will present compelling, irrefutable, I repeat, irrefutable evidence that the dural meningeal arteries are not involved in migraine and that they are not part of the trigeminovascular system, but instead that the terminal branches of the external carotid artery comprise the vascular part of the trigeminovascular system. In this presentation, I will present the evidence for and against the dural arteries and the evidence for and against the extracranial arteries. First, the evidence for dural artery involvement in migraine. The concept that migraine pain may emanate from the dura was first proposed over 80 years ago. Subsequently, it was suggested that there was a possible relationship between neurogenic inflammation, or NI, and migraine. The theory of dural involvement in migraine then received a substantial boost when Moskowitz and others proposed that migraine pain is related to neurogenic inflammation and vasodilatation in the dura, and introduced the concept of the trigeminovascular system. In 2019, Ashina et al. Published a comprehensive review of the evidence, which he claimed confirmed the role of the trigeminovascular system in migraine. Ashina emphasized, and I quote, "Now, more than 40 years after the initial proposal, the trigeminovascular system is widely accepted as having a fundamental role in this highly complex neurological disorder and provides a roadmap for future migraine therapies." The theory of dural arterial involvement in migraine has been repeated so often by so many prestigious champions that its basic error has come to be perceived as being true. Let's examine Ashina's evidence. He cited two studies which drew attention to the fact that the dura is innervated by the trigeminal nerve. But this is meaningless. Just because the trigeminal nerve innervates the dura, it doesn't prove that the dura are involved in migraine. The trigeminal nerve supplies many structures that are not involved in migraine. Ashina then presented evidence to show that cortical spreading depression induced a sustained blood flow elevation in the ipsilateral middle meningeal artery. But this was observed in rats and has never been demonstrated in humans. And as I will explain later, rat dura and human dura are very, very different structures. Ashina also stated that Moskowitz et al. Called attention to the key role that the trigeminal nerve plays in the innervation of the dura and the meningeal blood vessels. But that was a pure fabrication. Moskowitz never said that. Moskowitz theorized a possible role in migraine of the trigeminal nerve innervation of large intracranial and extracranial blood vessels. Although the dura are indeed innervated by the trigeminal nerve, there was absolutely no mention of the dura or the meningeal vessels in Moskowitz's quoted paper. Ashina also reported that substance P, a powerful vasodilating neuropeptide, is found within trigeminal afferents innervating the meninges. This is also true. But what Ashina omitted is that substance P is also found within trigeminal afferents innervating the extracranial vessels. But more importantly, it's far more abundant in the extracranial vessels than in the dural vessels. It's also interesting to note that substance P antagonists are highly effective in reducing dural inflammation in animal models. But several substance P antagonists fail to demonstrate any effect in migraine. The obvious conclusion is that substance P does not play a significant role in migraine pathogenesis. Moreover, substance P antagonists have no significant vasoconstrictive effect. Ashina also reported that CGRP, an even more powerful vasodilator than substance P, is also found within trigeminal afferents innervating the meninges. This is also true. But what Ashina conveniently omitted to report is that CGRP is also abundant within trigeminal afferents innervating the extracranial vessels. Iftikhari et al. Showed that calcitonin receptor-like receptor and receptor activity modifying protein 1 immunoreactivity co-localized with mast cell tryptase in rodents. But this is not evidence, it's meaningless. Expression of neither of these receptor components was observed in human dural mast cells. BIBN4096BS was the first selective CGRP antagonist. It significantly inhibits temporal artery dilatation. It is effective in treating migraine attacks. But it has absolutely no effect on the intracranial arteries, which includes, of course, the dural arteries. The presence of protein plasma extravasation, or PPE, has been shown to be an important component of neurogenic inflammation in rat and guinea pig dura. But this has never been demonstrated in humans. Electrical stimulation of the trigeminal ganglion in rats causes plasma protein extravasation in both the dura mater and the retina. So the presence of PPE in the retinal vessels signals the presence of dural PPE. But there's no PPE in human retinas during migraine, which suggests that unlike in rats, there's no intracranial PPE in humans. And what's more, PPE inhibitors have been shown by Perutka to have absolutely zero beneficial effect in migraine. Perutka concluded that the dural neurogenic inflammation theory of migraine is no longer tenable. This was as long ago as 2005. This evidence has simply been ignored. With regard to clinical imaging, Ashina quoted a paper by Amin that Ashina claimed reported that MRI studies showed that spontaneous migraine attacks are accompanied by intracranial but not by extracranial dilatation. But the extracranial arteries that did not dilate were the retromandibular part of the superficial temporal artery and the external carotid artery, which have never been implicated in migraine. It's hard to understand why Amin did not study those parts of the extracranial circulation that have previously been proven to be the source of migraine in many patients. For Ashina to make the misleading statement based on Amin's work that the extracranial arteries are not involved in migraine is nothing less than academic perfidy. Amin also reported that the magnitude of dilatation of the middle meningeal artery was minimal and concluded that it's unlikely that middle meningeal artery dilatation generates migraine pain. But Ashina made no mention of this. In a previous study, Schoonman et al. Determined that there was no difference in the diameter of the middle meningeal artery from baseline, nor between the headache and the non-headache side. They also came to the obvious conclusion that migraine attacks are not associated with dilatation of the meningeal vessels. So in summary, there's actually no evidence of human dural arterial involvement in migraine. The theory is based entirely on evidence from animal studies. There is, however, compelling evidence against the involvement of the dural arteries in migraine. Remember, the most important evidence of dural involvement in migraine was obtained from studies on rat dura. But as you can see, human dura is thick, about a half a millimeter, and it's composed of tough inelastic collagen, as opposed to rat dura, which is a single cell thick. The only thing that human dura and rat dura have in common is the name. It's like comparing a rhino hide to a butterfly wing. The human meningeal artery is encased in bone and thick fibrous dura mater, and it's impossible for it to dilate. Whereas in rats, the single layer of cells offers no resistance at all to arterial dilatation. The difference between human and murine dura is so significant that researchers have emphasized that rats should not be used as models for studies on human dura. Now let's look at histamine headache. It's been shown that dilatation of the cerebral arteries is responsible for the headache that follows the injection of histamine. And it's been shown that increasing the intracranial pressure reduces histamine headache by diminishing the amplitude of pulsation of the intracranial arteries, which of course includes the dural arteries. But Wolf showed that increasing intracranial pressure does not reduce the pain of migraine, which confirms that migraine pain does not stem from dilatation of any of the intracranial arteries, which of course includes the dural arteries. Now let's look at the evidence against the extracranial arteries in migraine pain. But before I present the evidence, I want to emphasize that this is all published, verified information. There is not a shred of speculation. The first person to present evidence that the extracranial branches of the external carotid artery are the source of pain in some migraineurs was Harold Wolff during the early 1940s. Now, Wolff's vascular theory had two components. The first part was that intracranial vasospasm causes the aura. The second part was that the pain of migraine often comes from dilatation of the extracranial vessels. But years later, Olison et al. Showed that during the aura, the pattern of cortical spreading depression does not correlate with the vascular boundaries of the major cerebral vessels. So the first part of Wolff's vascular theory was proven to be wrong. But this is where it gets interesting. In an attempt to discredit Wolff's theory, Goadsby later claimed that Olison had proven that vascular changes are unrelated to the painful phase of migraine. I repeat, vascular changes are unrelated to the painful phase of migraine. But Wolff studied the extracranial vessels, while Olison studied the intracranial vessels, the regional cerebral blood flow. To use Olison's study in an attempt to undermine the second part of Wolff's theory is both illogical and misleading, and it is nothing less, again, than academic perfidy. Goldsby deliberately misrepresented Oleson's findings, but this was not the only time that Goldsby distorted the truth to suit his own theories. But more on this later. In 2008, Schoenmann found that during migraine, blood vessel diameters were no different from baseline nor between headache and non-headache sides. But the only extracranial artery that he measured was the main trunk of the external carotid artery, which has never been implicated in migraine. He did not study the terminal branches of the external carotid artery, which are the only vessels that Wolff proved were involved in migraine. This didn't stop Goldsby from further deception. He wrote, migraine occurs without any change in intracranial or extracranial vessels. But here again, Wolff proved that the terminal branches of the external carotid artery were involved in migraine, whereas Schoenmann only studied the main trunk of the external carotid, which has never been implicated in migraine. What is more important is that this part of the external carotid is not even innervated by the trigeminal nerve, but by the carotid plexus. The second part of Wolff's vascular theory is that extracranial vasodilatation, without doubt, plays a part in some migraine attacks. So let's look at the plethora of evidence implicating the extracranial arteries. But before I present the evidence, I want to emphasize that this is all published, verified information, and there is not a shred of speculation. I would also like to emphasize that, as Harold Wolff pointed out, arterial dilatation is not the source of pain in all migraineurs, and that's why vasoconstrictors like the triptans and the CGRP antagonists are only effective in some migraineurs. Here's the evidence. Migraine pain can often be relieved by digital occlusion of the extracranial terminal branches of the external carotid artery. Migraine pain can often be relieved by temporal artery massage. Migraine pain can often be relieved by applying a tight headband, which compresses the extracranial arteries. A simple device causing prolonged compression of the temporal arteries aborts or reduces pain in a significant number of migraine patients. Periarterial infiltration of scalp arteries with 3 to 5 mL of saline caused significant improvement in 82.5% of patients, with complete cessation of pain in 52% of migraineurs. The superficial temporal artery is often prominent during a migraine attack. The temporal artery is significantly larger on the painful side than on the non-painful side. The scalp arteries are frequently painful to palpation during a migraine attack. Facial thermograms demonstrated significant differences in heat loss from the temples between migraineurs and controls, confirming that the superficial temporal artery and its branches dilate during migraine attacks. This patient had orbital and temple pain. The change in skin temperature took just a few minutes after pain relief. As is shown on the panel at the bottom, to the left, white indicates a higher skin temperature. After pain relief, the white area becomes markedly smaller and the cooler yellow area larger. Serotonin, from which the triptans were developed, is a potent vasoconstrictor of scalp arteries, but not of intracranial arteries. On exercise, the temporal artery on the painful side dilates more than the one on the headache-free side. The amplitude of pulsation of scalp arteries is larger between headaches in migrainous subjects than in normal subjects. The amplitude of pulsation becomes larger still on the affected side during a migraine headache. Biofeedback regulation of the temporal artery is frequently effective in reducing migraine pain. Blood flow in the extracranial circulation increases by 50% in the headache phase of migraine. Extracranial blood flow subsides at the same rate that the pain subsides. CGRP is a potent dilator of human superficial temporal arteries. And CGRP has been shown to induce migraine attacks in migraineurs. Also, CGRP levels are substantially increased in the external jugular during migraine. The G-pants were developed specifically to reverse the vasodilatation caused by the increased CGRP levels during migraine. The G-pants are strongly vasoactive and completely inhibit CGRP-induced dilatation of the superficial temporal artery. The triptans, the most widely used migraine rescue drugs, were specifically developed to reverse the painful dilatation of extracranial blood vessels. They potently constrict human temporal arteries, but they have never been shown to constrict dural arteries in humans. Relief of migraine pain with triptans coincides with reduction of CGRP in the extracranial blood. Ergotamine and dihydroergotamine strongly constrict the extracranial arteries. Not only that, but ergotamine and dihydroergotamine simultaneously reduce migraine pain and the amplitude of pulsation of the superficial temporal arteries. When the migraine pain reduces slowly, the amplitude of pulsation reduces slowly. When the pain reduces quickly, the amplitude of pulsation reduces quickly. Surgical ligation of scalp arteries permanently eliminates or substantially reduces migraine in patients positively diagnosed with vascular pain. But remember, one has to examine the patient to diagnose vascular pain. But in spite of the evidence, most headache specialists refuse to accept that the extracranial arteries play a role in migraine. So much so that in 2007, the American Headache Society specifically excluded all mention of the extracranial vascular involvement from their suggested curriculum for American medical students. One certainly cannot accuse the American Headache Society of having allowed their decision to be clouded by the facts. Professor Peter Goadsby was chairman of the International Headache Society from 2011 to 2013. He published a paper in 2009 titled The Vascular Theory of Migraine, a Great Story Wrecked by the Facts. In this article, Goadsby shamelessly distorted, manipulated, and obfuscated the facts, some of which I've listed above. In this article, Goadsby wrote, BIBN 4096BS is without vascular effects and constriction is not required since dilatation is not part of the process. And to substantiate these blatant lies, he had the gall to refer to an article by Peterson, even though Peterson said the exact opposite. Peterson actually wrote, BIBN 4096BS is strongly vasoactive and completely inhibits CGRP-induced dilatation of the superficial temporal artery. Not only that, But even the title of Peterson's article states that BIBN 4096BS antagonizes CGRP-induced headache and extracerebral artery dilatation. As Sherlock Holmes said, we tend to fall in love with theories, and then we twist the facts to suit our theories, instead of changing our theories to suit the facts. In reply to Goldsby's scurrilous article, I published two papers, one titled The Vascular Theory of Migraine, a great story confirmed by the facts, and one titled The Extracranial Vascular Theory of Migraine and Artificial Controversy, both of which Goldsby's deceptions and distortions were exposed. I would be happy to provide copies of both my papers and that of Goldsby to interested colleagues. The evidence is clear that the dural arteries form part of the trigeminovascular system is an illusion that has for years prevented real progress in the understanding of migraine. Only when researchers accept the fact that the vascular part of the trigeminovascular system is extracranial and not intracranial will migraine research once again be able to make meaningful progress. It may be an inconvenient truth to some, but the truth cannot be suppressed forever. And like a phoenix rising from the ashes, Harold Wolff's theory of extracranial vasodilatation will once more gain the recognition it so rightly deserves. I hope you found this presentation interesting, and I would appreciate your comments, positive or negative. Here is my email. Thank you.